Hello, everybody. My name is Dr. Lynn Klima, and I'm going to be your host for this presentation today, The Heart of Care, Integrating Ethics into Hospice and Home Care Settings. This content was developed by experienced nurses in home care, palliative, and hospice care, and we have no conflicts of interest. So, again, my name is Dr. Lynn Klima. I've been in healthcare over 40 years. I am a nurse practitioner focused in adult medicine. I have been working not only as a consultant, as a patient safety officer for QAPIplus PSO. I'm also associate professor at the University of Olivet, and my clinical focus has been in geriatrics, adult health, hospice, and palliative care. So I'm happy to facilitate our conversation today around ethics in the home care and hospice setting. So, our objectives today are to really just kind of do an overview and define those key ethical principles of autonomy, beneficence, non malfeasance, justice in home care and hospice, how professionalism folds into our ethical approaches to patient care in terms of how we develop strategies for healthcare excellence, understanding the professional impact that we have in terms of how our profession and professionalism really are the cornerstone for ethical quality and patient-centered care. And then we're going to talk about some ethical dilemmas using a structured decision-making model in terms of being able to think about how we would move forward with supporting a patient using an ethical framework to guide our decision making. All right, so just kind of as an overview, the key principles of healthcare ethics are justice, non malfeasance, which means do no harm, beneficence, which means we're acting on behalf of the patient for the patient's benefit, and then autonomy, being able to respect the patient choices. So we're going to kind of go through each of these. One of the things to think about in terms of your profession, I have an example here through the American Nurses Association, is that there are codes of ethics that guide our practice, right? And so in the ANA specifically, the purpose is to guide our nursing responsibilities that are consistent with quality of care. And it creates a foundation for the ethical obligations of the profession and how we would apply those standards of ethical conduct in nursing roles. So these are applicable to all clinical staff. Every discipline has their own code of ethics. So I'm just really kind of calling out here for you to go into your own profession's code of ethics and just be aware of what they are, right? We want to be able to understand what we're responsible for and what we are, you know, um, obligated to uphold. All right, so now let's talk about those ethical principles again when we think about the definitions with them. And we're going to start with autonomy because this is one that is really important in terms of how we support our patients, right? So, autonomy is the right of the patient to have control over his or her own body. And the patient has the ability to make those decisions for themselves, you know, how whatever's best for them. And when we think about different pieces to um, how we care for our patients, one component of autonomy is patients' rights, right? Their own ability to be informed about what's recommended for them, their diagnosis, treatment plans, those kinds of things, and what they want to do, what their own choices are, what their own preferences are, and having respect to uphold those preferences. And ways that we can do that are providing choices and respecting their decisions, even when we might disagree with the choice that they're making, or even when a family member might be, disagreeing. And we'll talk more about how this kind of all layers together when we're trying to help patients make appropriate decisions that are informed, that are in their own best interest, and then how we uphold those and how we, you know, um, support them. So one that is very common, I think, in the field that we're working in is those patients that have maybe made the decision, or they have the desire to, age in place in the comfort of their own home, right? Sometimes that's challenging based on the amount of support that they might need, or the resources that they have, or their medical condition in terms of, their frailty or their vulnerability, and who can or how they can be helpful. And so that's a choice, right? That they want to stay in place. And how do we, respect that and help them understand all those key facets that could impact their safety, and their quality of life by staying in that home. So, in terms of our roles as professionals and paraprofessionals, we can suggest or provide advice or counsel on, what we're seeing in terms of, their assessments, their clinical findings, their clinical outcomes. But ultimately, it's their decision. And if there's any conflict of interest based on the patient's beliefs or values, we would also want to, be able to get, as many people as possible involved in being able to help support them with the right amount of support that's going to keep them there in the safest way possible, right? And so this is one, I think, that we see front and center when we're looking at and caring for the patients in their homes. It is different. It's different than being in an acute care setting or a subacute facility where there is 24-hour availability of staff to support those patients. And so working collaboratively and collectively together, and then also making sure the patient understands the choices that they're making, but we're upholding that component, that principle of ethics in terms of autonomy, trying to honor the patient's choice in the best way that we can. So we can think about autonomy as a fundamental principle that respects the rights of patients to make those informed decisions about their own health care. And this can also include the right to refuse or consent to medical treatments, or to make choices about their care and have their personal preferences and values respected by those of us who are caring for them, right? And so when we think about the autonomy, it's again their choice in terms of, what they want to do, or how they want to approach a situation, the ability or their ability to decline whatever that medical intervention might be. And then how do we, fold that into our care plan, right? What are their personal values and their wishes so that we can honor and respect them? And again, we may not agree with their decisions, or their families might not agree with their decisions. We want to make sure that we're providing them all the information that we can so that they can make the most informed decision, and involve those people that are the closest to the patient, that the patient's willing and agreeable to having as a part of that decision making when they are making the choices about whatever it might be. So when we want to facilitate that autonomy or that decision making on the benefit of the patient, is, making sure that we're providing complete information, right? So when we're educating a patient about those treatment options, what are all the options? What are the risks of each of those options? What are the benefits, in a way that they can understand it, and that they can make decisions based on their understanding. So we also have to make sure, and this is one of those things in healthcare, that we speak a different language for many of our patients, right? We talk in that medical language, or that, medical ease. And not every patient understands that, right? There's terminology called health literacy. So in order for a patient to make an informed decision, we have to assure, and we're obligated to help them assure, that they understand what we've taught them or talked to them about, or that the provider or the doctor has talked to them about, and that gives them some time to make some decisions in a way, on information that they understand. And then we're validating that, right? So how do we know that they understood it? What's our way of questioning, or seeing that they demonstrated? Is it a teach back or a repeat back, or whatever it is? Are they able to, outline or tell us what, if I do this, this is what's going to happen, or if I don't do this, this is what's going to happen, right? So we want to make sure they understand them. And then we are in a role of advocating for them, right? We want to support that decision making and respect their choices without any undue influence, right? So a lot of times patients will ask us, well, what would you do? What do you think? Right? We're not in that space. That's not our job. Our job is to lay out everything for the patient with the information so that they can make that decision and help them identify who are other members of their family that could be involved in that to support them. Or if they need more time, or if they need to have more conversations with their doctors or their healthcare providers before they can make a decision, right? We want to give them as much time and space to be able to make that decision and maybe even change their mind sometimes, right? So we have to be more fluid and more flexible about their approach to care. All right, so this is kind of a nice little algorithm, right, in terms of being able to facilitate that autonomy, that independence on a patient end. In some ways that we can do it is by one, encouraging them, right? In one area that we're going to talk a little bit more about it is advanced directives and living wills, right? So we want to encourage patients when we're caring for them. If they don't have an advanced directive or a living will, this is a great opportunity to start having those conversations about what's important to them. What do they want to happen? Who do they want to be involved in their care, right? You want to get that written down and on paper and shared and communicated with all the important people. We want to provide patient centered care, right? So the care that we're providing, we say this all the time, right? In every encounter or every interaction with our patients, we want to make those care plans and the care as individualized as possible that's unique to them. It's not this, standard package or, you know, very clinical approach to things. We want to be able to modify it or change it in a way that's going to support them in the way that they might want that to be done, right? So I think about some of the support with ADLs, activities of daily living. Every patient is unique, how they, maybe they want to shower, maybe they want a bath, maybe they want to shower on these days of the week or in the afternoon, or um, what times their meals are, or what's included in their meals, or things that they like, right? It's not a standard everybody gets X. We want to be able to individualize that plan in a way that's very patient centered and focused on them. We want to provide appropriate education and training to patients and their family. This is really an important part of helping them be autonomous, right, and supporting their autonomy. What do they know? What are they already doing? What are things that they feel really good about? What are some things that might be gaps in their knowledge, right? We're great at educating our patients. We want to just tell them everything and share everything with them, but we want to start with finding out what they already know and what are they currently doing, and then what information do they need? What would they like? Not just, planting it all on them, but asking them what's important to them and kind of preparing that information for them. And if there's some gaps, right? Maybe they haven't asked about what do I do in an emergency? How do I take this particular medication? We can say, would you like some information about oxygen therapy? I see that you're on oxygen. Would you like more information related to that, right? We want to be invited into that space, not just giving it to them, but we also want to give enough information so that they can make good decisions about what it is that they want to do. We want to ensure. So, ensure means that consents and refusals are truly informed. We want to, again, validate that the patient understands the choices that they're making and they understand the risks of the choices that they're making, and that we feel there's a level of, I think, confidence on our end that we've done everything that we can to make sure the patient understands and they're decisional and they're able to make that decision and they've done it based on information that they've been provided, and consistently, going back and not badgering them about it, but just validating, do you have any more questions? I know in our last visit this was something that you had decided, this is the plan that we're working on now. How do you still feel about that? Is that still the direction you want to go? We always want to make sure that, if they have had second thoughts, or they've learned something new, or maybe it's not what they really realize. Sometimes they need a little bit of time to kind of mull it over, talk about it, and feel comfortable with the decision themselves. And maybe they've changed their mind, and that's okay, right? We also want to make sure that patients know their rights, right? That we're going to, support what's important to them and what their rights are. Sometimes our patients don't realize that they can say no to a treatment, refuse a treatment, end a treatment, ask for a different treatment. We want to make sure that they understand what their rights are. We also, as professionals, want to stay informed of any regulatory guidelines and laws related to the patients we care for, the populations we care for. Most of us, a large percentage of the people that we care for in home and hospice and palliative care are the elderly. So we want to make sure what those guidelines and regulatory guidelines are. We also want to, be advocates for them, right? If we're seeing or hearing things in our communities that are having a negative impact on the elderly, or maybe even a positive impact, we want to be advocates for them, right, in that political space, right, and advocating for laws that are going to impact them. And then know how to assist patients in accessing resources and navigating insurance in the healthcare system. So it is important to think about, you know, uh, what choices they have within the resources they have, right? And that's an important piece of how we work together with our team members to help us and help the patient understand that very complicated insurance world and the healthcare system, and how are things paid, and what gets covered, and why is this covered, and for how long is it covered, and where do I go, and who can I see. Very complicated, right? So a big piece of care coordination is about that. And all these things are really important in terms of not only facilitating the patient's independence to be able to make those choices and be autonomous, but also paving the space in, the climate in the community to be able to make sure that there are resources available to patients, and policies and laws that are going to support them as well. All right. We had talked about briefly already, advanced directives and living wills. So again, this is really a good space to start to have those conversations about autonomy and choice. What do patients want? So, as a care team member, it's important to know, does your patient have an advance directive or a living will? And where is that? Who knows about it? Has it been communicated? Does it need to be updated? If there isn't one there, how do we get one started, right? Who on the team is best to kind of queue up that conversation and then start that conversation? And sometimes people avoid these conversations because they don't, it reminds them of our fragility in terms of human life, right? And that, there will be an end. We will all be, dying at some point. And so sometimes people don't want to have these conversations because it brings the reality to front and center. But we want to make them feel empowered, right? While they can, to have choice in how things are going to go, right? And so the purpose of an advance directive is to really document in writing what their treatment preferences are, so that their family knows that they've thought about it in a time when maybe they're not too sick to think about it, and they can really plan and say what's important to them. And it allows the care to be guided when maybe there is a time down the road that they aren't able to communicate. It also supports their family. So a lot of times people don't realize, by putting these things down on paper, it helps the family down the line, the spouse, the caregiver, the significant other. So they don't have to guess and wonder, am I doing the right thing? Is this what mom would have wanted? How am I doing the right thing? I want to be able to, um, you know, do what I can and do it the right way. So advanced directives are a great place to have a conversation about the patient's rights and how they can be autonomous in their decision making. The other is a living will, right? So a living will also will, have those components of those treatment preferences, and then who's going to be the proxy in terms of, their designation and forms and things like that. So they're very important conversations to have to be able to facilitate autonomy. All right. Another thing that's really important in terms of, making sure that we're providing care in an ethical way is confidentiality and privacy. And we talk a lot about this in terms of HIPAA and protecting information, but we also want to make sure that our patients know that, we're going to treat their, uh, information in a confidential manner, and that we're going to keep all this information in a secure and a secure process so that they aren't going to we're not going to leak that information out to anybody. So it's important, part of that trusting relationship with us in terms of our care is making sure that they know how we're going to use their information, and that anything that's going to be shared, either whether it be with members of their family or across our care team or in that medical neighborhood, all those community partners that might be, you know, providing co-care with us for our patients, um, we aren't going to just share that information unless there's explicit consent for that. And that any documentation or records that we have are going to be, securely stored. And that we are following clear policies for handling that data, right? So, as staff members, it's important to know what are our policies around information sharing and data handling, and what trainings do we need to be, attending on a regular basis. And then, as organizational leaders, it's important to, have audits on a routine basis to make sure that the records and data sharing is not a breach against your policies that you have in place. And so, again, part of our process and, considering how we're caring for patients in an ethical way is to make sure that they know that we have a process in terms of disclosing information about them, and we're going to honor that and be, very intentional about that. And again, this is part of their choice. When you think about autonomy, who do they want to see that information? Who can we share that information with? And when you think about where we're caring for patients in that home care space, it's different than in a secure environment. Who's kind of coming in and out? Are there volunteers there? Are there neighbors there? Right. And so we want to be able to find out from them as a part of that process, who can have information, who do you want me to share information with? Because, people ask questions, they just want to know. It's not necessarily nefarious or ill-willed. They just care about maybe their neighbor or their friend. But we have to be really careful about how we do that. And in a more casual environment like a home care setting, ethically, it's easy. It could be easy to breach a patient's confidentiality, and so we want to make sure that we're being, very very careful about how we approach that and understand our organizational policies so that we don't have any mistakes or errors that take place. All right, now let's talk about beneficence, right? So, again, another ethical principle. And this basically is, the definition of beneficence is, that we are all charged as healthcare providers to do all that we can to benefit a patient with all recommended procedures and treatments intended to be for the best for the patient, right? So again, patient front and center. It's you and I, me and this patient, right? And our goal, my goal as that clinical staff person is that I'm going to be acting on behalf of that patient in their best interest. And how you apply that really is your principle as a staff person is you want to promote their well-being above all else, right? So doesn't necessarily matter what the wife wants or the daughter wants or the son wants. It's really about what the patient wants, and we put them front and center, right? And we try to do whatever we can to act in that patient's best interest. And this can be challenging, right? There might be benefits, and how do you balance those benefits against potential risks, right? So, patients who maybe are making choices that are not as healthy as they could be or in their best interest, and there might be some safety, at play, trying to figure out with them what's the best way that we can, balance those benefits and risks so that we can, you know, um, you know, not only help them be autonomous, but also, try to keep their best interests in mind and the choices that we're making and helping guide them on the safest path. One example that comes to mind here is that, I'll use oxygen as an example, patients that, are smokers, right? And, we don't necessarily want them to smoke for a number of different reasons, but when you have oxygen in the home or near the home, um, or in the same room as where the patient is, and they still want to smoke, how do you balance those risks out with the patient and have a conversation about, you know, is this a time for them to be thinking about quitting? And if that's not something that they desire, then how do you work with that patient to have the safest, environment for them? Again, to we want to promote their well-being, which is safety and optimal lung function and breathing. But is there a way that we can personalize their care in a way that maybe they can have a cigarette? I don't know. I'm not an advocate for that, and not saying that's the best scenario, but trying to figure out with the patient what are their best interests and how do we kind of honor that. All right, another principle is called non malfeasance, right? And this one sometimes trips people up a little bit, but basically it's about doing no harm. And it's intended for us to consider any decisions, made may harm another individual or society, even if it is made to benefit an individual patient. So again, it's another foundational principle of healthcare. When you think about, how are you approaching this? You want to again manage the potential harm in treatment, and it's important for staff, in our agencies to implement, strong risk management strategies and safety procedures and protocols and best practices for staff to follow. And we should have a good understanding of what those agency protocols and policies are for consistency of care. So when we think about non-malfeasance, we want to make sure that the care, the treatment that we're providing is, again, weighed out against the risks and benefits, right? So when you think about patients who are making choices about, maybe experimental chemotherapeutic medications or med regimens or um, taking medications off label, what are the risks and benefits associated with that? And then we want to make sure that we're doing and working with the providers to be able to proactively, think about those safety measures that we can prevent them. Think about, again, falls here, right? Those patients that want to be as independent as possible. And in an acute care setting, a fall is a never event. But when you get patients into their home space, they want to still stay independent and they may not realize that their condition is deteriorating. So, how do we minimize their risk for an injury, knowing that they're, still likely to want to get up and do things? How do we educate the family? What supports do we need there? What kinds of supportive, devices do we have? What can we put in place so that we can, have them maintain their level of independence as long as possible in the safest way possible? Fall might still happen, but we want to minimize a fracture, a break, a head injury, whatever. The other is societal impact, right? So considering broader implications of decisions, right? And so when you think about some other exposure risks to other people. I think about, some of the infectious disease processes, tuberculosis, for example. You might have to restrict a patient's, movement and where they're going because they have active TB and maybe they're refusing to take their treatment. And so we want to minimize their exposure risk outside of in the community and to family members and those kinds of things. So there is that greater good that we have to account for and come up with a safe plan in a way that maybe isn't honoring every wish the patient has or desire the patient has because we have to also think about the exposure and the spread and the risks to others with exposures to TB. So that's just another example that would be where there would be a greater impact to the society that we want to do no harm to the patient, but we want to minimize the impact to others who could be impacted by that type of an infection. All right. Another ethical principle is justice, right? And this one's a little bit easier to kind of understand, I think. Basically, it's the ethical distribution of healthcare resources, ensuring that there's fairness and equity and access to care. So we're fairly distributing those resources and we're looking at health disparities and access to care, right? So if you have, done any readings or looked at in the literature, we know that, depending on the community you work in or the populations that you're caring for, there may be issues with access to care and resources. So part of our ethical decision, our ethical principles is that we are working to assure that we have, a fair distribution and that we are in, that there's a fairness in our medical decisions. And for, home health care providers and hospice providers, it means having a policy in place to provide care and treatment and services to patients without regard to their age, their race, their religion, their sexual preferences, their national origin, or their disability, right? The services we provide are equal to all the populations that are asking for our services. And it also requires that we are in compliance with both federal and state regulations that govern them. So when we think about health equity, we're looking at those disparities. What are those things that they call the social determinants of health that would get in their way, right? So maybe geographic barriers, how far are they in terms of being able to get services? Maybe there's socioeconomic factors. So again, maybe they don't have insurance, they're underinsured. Um, Maybe they have cultural considerations in terms of their belief systems and those kinds of things, right? So when we're thinking about that ethical principle of justice, we want to make sure that there's a fair distribution of how we're providing care and services and that we are looking at those barriers that are we want to minimize so that we are assuring that all the patients in our service area have access to the same kinds of services in an equal way. Healthcare ethics also, can includes, and then that's really we've kind of just talked about a high level overview, but there are also, you know, um, complex issues, right? We talked a little bit about informed consent and confidentiality. We're making sure patients understand the information we're giving them, that, we're going to keep their case or their information confidential and private. And that can all be dicey, right? Like maybe family members, maybe they don't want their family members to know. Maybe they don't want to share information. Maybe we're not sure if they are understanding the directions, right? All these things can be very complicating in terms of how we're providing care and are we, what's the most ethical way to approach these situations. Other areas where it becomes, complex is end of life care. Patients, are they, ready to consider more of a palliative approach to their medical treatment plan. Maybe they're ready to enter hospice, but their family isn't, or maybe their care, in terms of their treatment options is exhausted and there's nothing else we can do or provide or offer for them. And so having those conversations about hospice and so all of these are, really kind of we're in the thick of it, right? And being able to help support and advocate for those patients so that they can make the most appropriate decisions for them. Um, so also some things that, yeah, can make it be more complicated are, certainly healthcare policies, insurance coverage, right? So we've all probably seen directly the impact on, what resources a patient can get based on what insurance they have, what they can afford, where they live, and so it's hard, right? When you think about what is the best approach, or how do I make the best approach, or what is the best decision, and these are really kind of collaborative discussions, right? This is not one person on any team making those decisions. It's the patient as the guide, right? They're at the center of our decision making, but these are those conversations with those appropriate team members, right? So if you have an IDT team that you're working with, or other roles within your organization, like social works, pastoral care, or spiritual care, certainly providers, maybe the primary care provider, how does everybody work together with the patient and their family to make these decisions? And there are a number of different frameworks that are out there to kind of help guide and create a process to kind of work through and collect the information and move forward. But we're going to kind of focus on one framework today, just as we go through the slides to talk about them. So we've talked a little bit about end of life decisions as being one complicating factor, privacy concerns. There's also research ethics, right? In terms of patients that maybe we don't see this in home care and hospice, but that are a part of research studies, right? And so those that are in the research field have a lot of ethical obligations around the types of studies and enrolling patients and communicating with patients and that sort of thing, and being honest and having voluntary, human subjects, right? When you're working with human subjects, there's a whole process to go through that patients, when they sign up to participate in a research study, there have been an ethical process that they have followed along with the researchers to assure that they're informed about what they're participating in. And then resource allocations, which we, talked a little bit about in terms of how do you, work with the constraints of what's available to the patient, or what they can afford, or what's available within their community. So we'll talk more about those through a case as we go through this presentation. Another thing that's really important, and I don't know that we really think about it in terms of ethics, but it's really about promoting professionalism in healthcare and how we approach our patients, right? So a lot of us might define being professional as, being on time for work, being dressed appropriately for work, having everything that we need for work, treating our patients in a respectful manner, communicating with them respectfully. All good, all very relevant. But we also want to think about just, how not only how we're conducting ourselves, and our team members, but also those behaviors and attitudes and values that we uphold in practice, and recognizing that professionalism is also a foundational concept or component of ethical care, right? We want to make sure that we understand that who we are and how we conduct ourselves, in practice. That's all really part of ethics, right? And so some of the key components of professionalism are, we're going to kind of go through here, but competence is one of them, right? So when you think about being professional, do you have the knowledge and skills for effective practice, right? So there's a lot of self evaluation or self reflection on that. There's also, how your employer, your team leader, or your manager, or your, clinical lead evaluate your clinical skills. So you don't want to, have somebody working with you that has a license that has not been expired, or they aren't licensed, or they're not properly trained for their role. They're not ready for the work that they're being asked to do, or not competent in being able to do that. So that is not only an obligation of as individuals to make sure that we have those skills that we need to do our jobs, but also our employers that they're giving us the resources and taking the time to orient us and prepare us because our patients expect that, right? When they come to our organization for care, they expect that the people that are working there are competent, right? That we know how to perform our duties effectively and safely. Now, there's integrity, right? That we are honest, we are principled, we are accountable for our own actions, right? So we all know mistakes can happen in healthcare. It's not that we are perfect humans. There can be times where mistakes are made, but we are following an ethical model, right? That we have integrity, we're maintaining honesty, we're being transparent with our patients. If there is an accident or something that takes place that we're not sure of, we're communicating that, we're being open about it, we're being accountable for our actions. Respect, I think this is one that we would probably all, list in terms of, being professional, that we're valuing the dignity and again, that autonomy of patients, not only our patients and their families, but also our colleagues that we work with, right? So even if we may not, be best friends with, our other team member, they are our colleagues. And so we want to be respectful in our actions and our communications to them and about them. And then also other stakeholders in the healthcare system. So providers on our team, people in the community that we work with, right? We want to always uphold that professional standard of being personable, professional, and not blaming, not accusatory, just be, really respectful of everybody. The other is compassion, right? And most of us go into healthcare because we care about people, we're empathetic, we want to help, we want to do the right thing. So, again, demonstrating empathy and providing care that addresses not only the physical health, but also the emotional and psychological well being of our patients. Very important. Also, that we're looking at that whole picture, everything about them, right? And we're going to see people at their most vulnerable and their family members at their most vulnerable, and so it's going to be hard, it's challenging, right? It's hard sometimes for the way that maybe we're getting treated, or we might be the recipient of some anger, some frustration based on what's happening with that patient or their family and their healthcare journey. We know that work violence against healthcare workers is on the rise. It happens in um, every component or sector of healthcare. Home care is not spared from that, and so it we still have to have that compassion, though, right? And safety is critical, and we have to work with our leadership to assure that we feel safe in following our safety protocols within our organization. But we also have to remember that we have to try to approach people with compassion and understanding. Communication. We communicate in so many different ways. We do verbal communication, nonverbal communication, through technology, right? So you might have a device, you might have a computer, we might be on the phone, using those, secure channels of communication. Our documentation, right? How we're documenting, what we're documenting, are we being timely in our documentation? Those are all that's all a part of professionalism, that we're making sure that we're covering all those things that we need to cover so that the next team member knows and that they don't have to have that information repeated by the patient, and we're all aware of what the patient's care plan is and what the changes are and those kinds of things. And then commitment to service, so prioritizing the needs and welfare of the patients over any personal gain, right? Our goal is to be able to support them. So those are some key elements of professionalism. Why is it important? So, again, just to kind of think about that trusting relationship with the patients, right? So, if we're professional, they're going to feel like they can trust us. If we have higher standards, we're going to provide better quality of care. So if our organization has high standards for us, but we also have those high standards for ourselves, that's going to, that's going to come out in the way that we care for our patients. And then it also elevates that ethical practice, right? So it helps us think about and um, be more cognizant of those complex moral dilemmas that we might find. So, professionalism promotes ethical behavior. It helps us navigate those more moral complex dilemmas and helps us get to a way that we can deliver care in those situations that aligns with those ethical principles, right? Are we giving that patient autonomy? Are we doing it for the benefit of the patient? Are we doing no harm? Is it a just approach to care, right? Thinking about those principles. Collaboration, right, enhances communication and teamwork, right? So we have to work together. Don't feel like you have to do it all or the burden is on your shoulders, right? We work with teams. How do we work together as a team? How do we communicate together as a team? We know, we're all measured in terms of patient satisfaction. We want to make sure that you know how we're providing our care to our patients. If we're following those professional elements, we're going to see those satisfaction scores that are going to be higher. And if you were looking at the research, communication is one of those interventions, the way that we communicate and how we communicate with people that can really make or break your patient satisfaction scores, right? You might deliver solid care, but if you're not communicating in a way that the patient feels heard or attended to or respected, they may not either do their evaluation, their satisfaction uh, um, survey card, or they may do it and give you lower ratings, even though you did everything you were supposed to do. It's just, again, that relationship didn't get built by the way that we communicate with each other. And then it continues to build our professional reputation, right? Not only for ourselves as professionals, our organization that we work for, but just in general, the healthcare field, right? We want people to trust us. We want them to, when they know that they're making a decision to have a patient cared for in the home or enroll in a palliative program or a hospice program, that they can feel a level of trust related to the services that they're going to receive because they know that we're professional, we're a professional organization. Some ways that we can promote professionalism individually, but also as organizations, is one to just to have those basic competencies in terms of what we're expecting of ourselves, but also growing in our professional development, right? So, how we're communicating to our patients, families, and team members. How do we demonstrate empathy? Are we accountable for the work that is being assigned to us and diligent about completing it and following through and documenting what we've done? Um, Participating in educational offerings and professional development, whether they're offered by your organization or your company or outside sources, right? So always be lifelong learners and seek opportunities to improve, in areas that you're interested in around the clinical work that you're doing. And then at an organizational level, really having a culture that supports, you know, staff to be professional and what those professional expectations are, and holding people accountable for professional behaviors, but also having a committee structure or a review panel to help go through debriefings, right? Like those challenging cases, we all have them. So it's really nice to be able to have a group of colleagues that can look at a case while it's happening, right? So to be able to debrief and say we're struggling with this, this, and this. How do we, what can we do? What are the recommendations? Or after a case, right? If something has happened and it didn't feel good or it was overwhelming and it's very stressful, and you know what those cases are like, right? We feel them. We've all been in them. So how do we do a post review of those cases and what we could have done so that we're all learning so that we can get better at it, right? And that the policies that the organization may develop or need to be modified or revised, support some of those things that we've learned from those ethical reviews and patient issues so that we're getting better and we can avoid them in the future. So we've talked about collaboration. It, when we think about how we enhance not only ethical practice and professionalism, it is important to promote and focus on how we work together in an interprofessional way. That's across your teams that you're working with, but it's also team members within the community. Teamwork is is important, especially around ethical decision making and how each discipline might look at something. And this is, when you're thinking about ethical reviews, it's really all roles, right? So from the home health aides all the way up through the provider and leadership staff, it's important to really be, have representation from each one of those roles as a part of that review process and be able to approach you know, uh, recommendations from the perspective of that group and then come together, in terms of a summary set of recommendations. And that supports the building a culture of shared values, right? We're all aiming for the same direction. We all might approach it a little bit differently based on our discipline, but we're respecting each other's opinion and sharing our values and you'll end up with some really good outcomes that way. There are also is the opportunity to use an ethics framework and guidelines. So, um, does your organization have a code of ethics? What's it based off of? Where is it kept? Do people know it's there? Do people look at it? How is it trained out? What is your model when you have those patient situations that come up that are challenging and difficult to work through? How do you approach those? What's the model to be able to do that? Um, how do you use your team meetings or your IDT team meetings or debriefings or staff meetings to review different ethical issues and scenarios and, look at case studies and walk through them and do some role playing. And so those are really important things to be intentional about so that you're not trying to dissect something while you're in the middle of it. The more that you can be anticipatory and coach and mentor and learn as you go, it's going to strengthen your confidence in how you approach some of those decisions as you're working with some of the more challenging patients that we're all faced with. The other thing is, in terms of a culture of safety, encouraging open discussion and reporting. You want to have safe channels for raising ethical concerns, can be from patients and families. So, is there a way for them to report ethical concerns or other community members? Maybe they have been a part of a patient's care and they have concerns. So, what is that? How does that play out in your organization? Or from staff to staff, right? Is there a way for a staff person to bring up questions about things that they might not feel comfortable about? And then policies in the organization for potential whistleblowers and ethical reporting mechanisms. So, just some things to think about as we go forward. Okay, so let's talk about one model of ethical decision making. Now, there are a number of them that are out there, right? So, this is not the only one. This one is a good example, though, because um, I think it's very straightforward. It's an evidence based model, and it's a kind of a nice, clean way to kind of go through a process, right? And so it's called the four box model of ethical decision making. And the four boxes are medical indications, patient preferences, quality of life, and contextual features. So after considering all four of the boxes, we'll go through each one of these content areas. The healthcare team can weigh the medical indications against the patient preferences, the quality of life, and contextual factors. And because this is such a holistic approach, they can arrive at an ethical decision that respects the patient's wishes and promotes their well being. So it's kind of a nice, kind of clean way to kind of outline what's happening with each of these things and then kind of going through them. So we're going to talk about a case here in a couple of minutes using the four box model of ethical decision making. One other thing I think that's helpful, and we're not going to belabor this, but it's also important to understand some ethical and legal terminology. So I have a few words here that would kind of fit under that type of terminology. So conflict, moral distress, moral uncertainty, moral dilemma, moral sensitivity, fiduciary, beneficence, non-malfeasance, negligence, failure to rescue, advocacy, confidentiality, fidelity, veracity, justice, autonomy, clinical competence, and standards of care. So, just some legal and ethical terminology as a quick review. All right. So when we're thinking about that four box model, um, one of the first box is actually the medical indications, right? So when you're have a case in front of you that you're going to review, the first thing to think about is and dissect is those medical indications. And, so what are the medical, what's the medical problems the patient has? What are their goals of care? Is it curative? Is it palliative? What are the other treatment options? What are the benefits, the risks and burdens of those various treatment alternatives? So, for example, if you had a patient with advanced cancer, they may have options for chemotherapy, palliative care, or hospice services, right? And so you're, kind of dissecting that based on what their medical conditions are, what the diagnosis is, maybe what stage of cancer they have, what their current treatment is, and then what are some of the other options that are out there with the risks and the benefits, right? So you're just kind of laying it all out there under the medical indications. Next is then the patient's preferences, right? So what does the patient want? What are their goals and preferences regarding treatment? Have they been adequately informed about their condition and treatment options? So again, that informed consent. So example, the patient expresses a desire to prioritize quality of life over aggressive treatment, opting for palliative care, right? So even though there were other options that were provided to the patient in this cancer scenario, they're choosing palliative care. That's their preference. All right. And then under quality of life, we're looking at, how will the proposed treatments affect the patient's quality of life? So, again, what are not only the physical impact of those treatments, but also the psychological and emotional impacts, right? And then consider, are there any concerns about harm versus benefit, right? So, how will that treatment what will it how will it impact their quality of life? And then, weighing out the harm versus the benefits. So, an example here is, comfort care preserving meaningful time versus suffering. So, an analysis shows that aggressive treatment may shorten the patient's remaining time with significant suffering compared to opting for comfort care, right? So, again, in that choice for that patient, if they're going for quality of life and they want to spend time with their family and they don't want to spend time in the doctor's office or in the chemo chair getting those treatments and then being sick and their condition deteriorating, conditions will still deteriorate, but they might be comfortable, right? More comfortable. So again, weighing out those risks there. And then the contextual features are those social factors. What are the social, cultural, legal, and financial implications involved in their decision? Also, here's where you want to consider the family dynamics. What do the family members or caregivers believe or want, or what's their influence in the decision making process? And so, in the example, we're kind of talking about here is the family is supportive of the palliative plan and is aligned with those patients' values. So, once you've kind of laid it all out in these four boxes, um, then the team, that healthcare team can come up with a recommendation that respects the patient's wishes and promotes their well-being, right? And it may not be our choice, right? The doctors may have wanted them to try something for a period of time, or wanted to do surgery and a chemotherapy, or whatever the treatment options were. And so this is a way that, kind of breaks it down. And this was a very simplistic case. So the more complicated the cases are, I think it's really important to have this thoughtful approach to be able to get at it. And if you have every team member do it from their perspective, there might be different ways to consider how you approach it. So, again, I think, that's a great opportunity to be able to think about that. And some ways to, think about using that process is, our goal in home care and hospice is to provide compassionate patient-centered care. And so, if we have any issues that are coming up related to privacy and issue, in terms of what the patient is willing to share or doesn't want to share, what they know in terms of their abilities to be able to make decisions. Maybe they're at that point where they're making end of life decisions, or cultural considerations in terms of what they might believe or their beliefs and practices. These are some things where you might want to use a more of a structured approach in terms of determining the next steps of care, because of the ethical implications of that ultimate decision. One place that is also relevant when we're thinking about an ethical approach is around that intersection between culture and religion, and in terms of the importance of the religion or the religiosity of of the patient and their choices. It can influence their values, their beliefs, and their medical responses, and what they would, determine in terms of their treatment preferences, their end of life perspective, how the family's involved. And so we want to make sure that we're, attending to, those things that are gonna be relevant to the patient. Um, Cultural and religious considerations play a significant role in healthcare ethics. And we want to be able to make sure that we're understanding these considerations, and that it's essential in terms of providing respectful patient centered care. Um, by acknowledging and respecting diverse beliefs, uh, we as clinical team members can enhance not only the patient's satisfaction, improve their health outcomes, and uphold ethical standards in patient care. And then also paying attention to culturally competent practices that are going to foster an environment that's inclusive and empathetic and responsive to the unique needs of each patient. So those are important things to think about when we're working on thinking about ethical dilemmas. um, so again, some areas where there's some consideration or attention that need to be, you know, played out here are, in terms of culture, religion is cultural competence, right? So it's what that means is it's the ability of us, the healthcare providers, to understand, respect, and effectively respond to the culture and language needs of each patient. And this is important because culturally competent care improves not only our communication with our patients, but it also enhances trust and leads to better health outcomes by acknowledging and respecting, the diversity and in terms of those cultural backgrounds. Respect for diverse beliefs. Our patients may hold different beliefs related to health and illness, treatments based on their cultural or religious backgrounds, and these beliefs can affect their decisions about how they want care to be done, what treatment options they're going to select, and end of life issues. So some examples would be that some cultures might emphasize more of a holistic approach to health, while certain religious beliefs may prioritize spiritual healing over conventional or typical medical interventions. Here's again informed consent and autonomy. This has shown up multiple times right through our presentation. And again, different cultures may have varying beliefs about the concept of autonomy and informed consent. And while some cultures encourage individual decision making, others may place a higher value on family or community involvement. So, in terms of our practice, we need to be aware of these differences and involve those key players or those key family members or cultural mediators in discussions when appropriate, making sure that the patient's rights and preferences are respected. When you think about end of life care, beliefs about death and dying vary widely. Some cultures may prefer aggressive measures to prolong life, while others may prioritize comfort and quality of life, favoring hospice or palliative care. So, understanding that patient and family beliefs is important in terms of, resuscitation or DNR orders, life support measures, organ donation, all those things that can come up. So again, that's where those advanced directives, are critical in terms of determining and defining what that patient would want. Dietary restrictions, right? This is true for across all healthcare, spectrum, acute care as well. Certain religions and cultures have specific dietary, requirements like being kosher in Judaism, halal in Islam, vegetarianism in some Eastern religions. So these restrictions can impact patient care, especially, with some limitations of how or who people in the home might be getting their food or preparing their meals for them. We need to know what those are, what those dietary preferences are, or those restrictions are, and accommodate them when we're planning or helping plan for nutrition. Oops, I lost my spot. Okay. And then language and communication barriers. So language, is effective. Communication is critical in healthcare. Language barriers can lead to misunderstandings about treatments and care and treatment or understanding. So if we have to have interpreters assessing how people best learn, what kinds of educational materials, documents, things like that would be helpful for them. And then we also want to think about spiritual care. So when we're thinking about the role of spirituality, many patients find comfort in, spiritual or religious beliefs. Um, so we want to make sure that we're, providing access to spiritual care and addressing their needs, and that can, overall enhance their overall well-being. So who on your team does that? What resources do you have? What kind of spiritual counseling services are available? What are those protocols? So there's a lot of different ways, things that we have to attend to in terms of culture and religion when we're thinking about that ethical decision framework. And we want to make sure that whatever ethical model, decision making model we're using, we want to make sure that we're attending to the cultural and religious factors, recognizing the significance of these elements in their, in a clinical judgment, and involving, like we said, the interdisciplinary team. It can facilitate decisions that respect those diverse values and beliefs. All right, so we've talked already a little bit about all of these. Navigating ethical challenges in home care and hospice, is a delicate balance of patient centered care, caregiver well being, and consistent ethical frameworks to ensure the highest standards of care and dignity. So we've already talked about end of life care decisions, balancing privacy and safety. We haven't talked about caregiver burnout, so we're going to talk a little bit about that now, because that is important to be able to address the emotional and physical toll on home health care workers, ensuring that our own ability and well-being to provide care is attended to. All right, so caregiver burnout. So ethical obligations of caregivers. Caregivers have an ethical obligation to provide high quality care to our patients or clients, and this includes being attentive, compassionate, and responsive to their needs. But we know there's significant risk to being burned out, whether you're a caregiver that's in the home with the patient all the time, so as a family member, but then also our own team members, right? Our group of people that are working with the patients that we're, caring for. So, what we do know about burnout, it can lead to a decline in quality of care, where it puts us at a greater risk for increased medical errors and a lack of empathy towards our patients. And this can have serious ethical implications. And, when we experience burnout, it can negatively impact the well being and outcomes of the patient and their family, and it raises concerns about our duty of care. So, there are different strategies to employ for addressing burnout, but the goal is really to prevent and manage burnout so that we don't get to that point where we aren't feeling any empathy or are putting our patients at risk by the care that we're providing, and we want to be make sure that we're attending to that. So that's one thing to think about. So the other, I wanted to talk about informed consent again too. When we think about making sure that the patient understands that the choices that they are being given is done in a way that um, allows them to exercise their right to self-determined care. So the information that we're giving them must be accurate, complete, and understandable. And elements that we have to include are, their disease process, their prognosis, the purpose of proposed treatments and procedures, potential risks and benefits of the treatment procedure, their risks and benefits. Uh, what are the alternatives? What is the effect of no treatment, decisional capacity of the patient. We're going to talk about that in terms of how we assess it. And then in terms of uh, voluntary, in terms of the patient making the choice, we want to make sure that there is no force or coercion or undue influence in terms of the decision that they end up making, and that there's a consent of patient, right? So when we're thinking about those ethical challenges, we've talked about caregiver burnout, now we're thinking about informed consent again, right? All those components in terms of a patient we're making sure that they have, you know, um, they understand the decisions that they're making, and we're giving them the time and the space to be able to make those choices without influence, and that it's clear that they're making it, the consent, what's the decision or the agreement in terms of how they're proceeding. But one ethical dilemma that comes up is, you know are they decisional, their decision making capacity. And it's important to be able to make a clinical assessment of this. And if the patient demonstrates, a good response or a satisfactory response in all these categories, then the patient is deemed able to make their own decisions. And this again might take more than a member of the team, right? So we're all collectively working together with the patient. So part of that, understanding is that informed consent. Do they understand their diagnosis, what their options are? Are they appreciating the significance of their decisions, recognizing the implications? So if they make this choice, that means X. If I make this choice, this means X. That they have the ability to reason about the options. So they're actually comparing choices and consequences. And that in terms of communicating their choice, they're clearly expressing, a consistent decision about, what they want to do or what they want to move forward with, right? So this is one of those ethical places where are we, 100% sure that that patient is able to make that decision independent? Are there other things that are getting in their way, maybe memory loss, maybe medications, maybe their declining condition. So this is very important piece of, when they make a choice that maybe is questionable, or maybe sooner than we would have expected a patient to make a choice in terms of their prognosis and treatment options available. We want to make sure that they're decisional and they have the appropriate capacity to make those decisions. If the patient is not, right, we y- in terms of if they are competent, they have that mental clarity and appropriateness for decision making based on their mental status exam. They have the right to choose, right to be informed, right to refuse treatment, and the right to participate in their care. And legal competence is determined by the court and may result in legal guardianship if we think that they're not able to make those decisions. And then guardianship would put in place a legal appointment of a person to make those decisions on behalf of the person, and the person is deemed by the court to be incapable of making her own decisions, and guardianship versus limited guardianship versus conservatorship. So there's a variety of different terminology here. So again, when you think about going back to the advance directives and who's going to be the medical decision maker for the patient should they not be able to communicate for themselves, we want to have that early on in the beginning, right? So that it doesn't end up into this guardianship situation, and it helps the patient right from the very beginning be more involved in determining you know what their care would be. But this is one area, I think, when we're thinking about ethical dilemmas that we might see in clinical practice. It's, is that person able to make the decisions? And then if they don't have a clearly documented plan, how does that fold out, or how does that play out, and who makes those decisions for them? Another thing to think about is the quality of life versus sanctity of life. So this is also kind of one of those ethical things that will come up. Quality of life, personal perception of conditions of life, and the degree of acceptability of such conditions, the sanctity of life, the ultimate value of life um, itself is sacred and inviolable, and the right to live, and then patient rights, right? So, in terms of maintaining that life and what those patients' rights are, and how that could play out in a dilemma in terms of choices, in terms of ending life, um, as we're moving forward with decisions as a patient's condition is deteriorating. When you look in the research, uh, quality of life is defined by three main categories in terms of where patients sort of rate what they want maintained so that they feel like they have a quality of life. So, first is physical needs, right? So that their pain is managed, they're comfortable, they're able to move around, they have support for mobility. So that's ranks really high. Like 90% of people are that's really what they can think of when they think of quality of life. Next is emotional needs, that they have psychological support and meaningful connection. So they're not isolated, right? That there's that interaction with people that are important to them, and they feel like those needs are being met. And then 80% is spiritual needs, that they have, this existential peace. There's been meaning to their life. They have support from their faith community. So those are the things that they're focused on, that people want to see in terms of how they would measure, or uh, say that they've achieved a quality of life. Let's help us take care of our physical needs, our emotional needs, and our spiritual needs. When you think of end of life decision making, this is another area where using that box model to think about recommendations in terms of how to approach a situation. The first in terms of rights of the patients is that advance directive, and it supports their autonomy and having their understanding of documenting those wishes for future care. The next is then, when do they explore the role of palliative care in managing their symptoms and improving quality of life? When you think about all those patients with complex chronic illnesses or terminal illnesses where the treatment plan has been maxed out, the diagnostic workup isn't going to show up anything different. So, when does a patient make those choices in terms of not ending treatment, but maintaining everything where it's at and moving into that palliative sector, so that we're just managing the symptoms and helping them, with those quality of life needs. And then the next is, at what point are they ready to go into hospice care and, learn about the benefits of hospice and how it can provide compassionate support for both the patient and their loved ones, right? And so those are kind of, where you'll start to see, um, you know, these are the opportunities, right, in terms of thinking about how we, engage patients with that advance directive. And if there isn't one there, that can complicate things. And that's where we get into some of those ethical dilemmas about those choices and how to proceed with a patient when that's not been clearly expressed. And if the patient's not able to make those decisions, how does that take place? The other is then when, making those decisions in terms of how do you, start to move into that palliative approach to care and then that hospice care. And then once, we're in hospice, we're also thinking about, or even not even just in hospice, but, at that terminal stage, withdrawing life support and the ethical considerations around the decision to withdraw life sustaining treatments and the implications for patient and family, and then assisted suicide. So the complex debate around euthanasia and assisted suicide and the legal and the moral considerations involved. And those laws vary state by state, so it will look differently for every state. But those are, again, when we think about end of life decisions, those that space in our care that we're providing where we might see those moral or ethical dilemmas come up where we need to have more of a approach with an ethics group or an ethics committee to be able to decide what to do. All right, so let's kind of put it all together a little bit using the four boxes with a patient called Mr. Smith. And Mr. Smith has terminal cancer, and we're going to use that four box model for decision making and come up with the best course of action that's going to honor his patient values. So, again, it's a holistic approach that respects the patient's wishes and promotes their well being. So, when we think about the medical indications, Mr. Smith has terminal cancer and he has a prognosis of weeks to months to live. Um, Curative treatment options are no longer effective. And the goals of care, the primary goal is to manage pain and symptoms effectively while maintaining comfort as he approaches the end of life. So the treatment options include continued hospice care with pain management medications, nutritional support, and considering adding any interventions for symptomatic relief that he might have as he's, progressing in hospice. So when we're thinking about the medical indications, this is kind of how we would, kind of think about that, the clinical aspects, the goals of care, and then the treatment options that are available to him. The next box in the model is the patient's preferences. So Mr. Smith has expressed a desire not to undergo anything aggressive that might prolong his life at the expense of his quality of life. And he has indicated a preference for comfort measures only and wants to spend his remaining time with his family without intensive medical intervention. And the family involvement, he's discussed his wishes with his children who support his decision for hospice care and value his choice for a peaceful death. So this is his wish now. He doesn't want anything aggressive. He just wants quality over quantity, comfort care, and prioritizing family time. And his family is in support of his decision. When we think about the quality of life, the hospice team assesses that continued aggressive treatments like chemotherapy would likely lead to increased discomfort and side effects, further detracting from Mr. Smith's quality of life, and assessing his harm versus benefit. Pain management and supportive care align with his wish for peace and dignity at the end of life. So pursuing aggressive treatment could cause more suffering without meaningful benefit in terms of prolonging his life or longevity or quality of life. So our conclusion here would be focusing on comfort care would enhance Mr. Smith's quality of life as he nears the end, allowing him to engage with family and have a dignified passing. Some contextual features to think about. Social and cultural, his family is actively involved in his care and they understand and respect Mr. Smith's wishes. Additionally, the family embraces a cultural perspective that values quality over the mere prolongation of life. Legal and financial considerations. Mr. Smith has advanced care planning documents in place, i.e., a living will, and an appropriate insurance coverage for hospice services. The family is aware of his choices and supports them, and resource availability. The hospice team has the necessary resources to provide home health care, emotional support, and symptom management. So, our conclusion with Mr. Smith is that the best course would be to continue in hospice care, focusing on comfort. The ethical focus is that we're, focusing on respecting his autonomy and optimizing quality of life. And we're doing a holistic approach where all factors are considered for compassionate care. This decision center, respects not only his autonomy, optimizes quality of life, and ensures that his final days are spent as he desires, surrounded by supportive family members. Sorry. So, this structured decision making process highlights the ethical considerations in caring for a hospice patient, ensuring that all factors are considering in delivering compassionate and appropriate care. So, I think that, it's kind of a nice, clean way to make sure that we attend to all the different things. There's a lot always going on with our patients, but it puts it kind of into a focused assessment of, the perspectives, from the medical point of view, the patient's point of view, the quality of life features, and then any other contextual things to help us kind of guide a decision. So just, kind of wrapping up what we've been talking about in terms of key points, in terms of things to walk away from. Patient autonomy, front and center, right? We want to respect our patients' rights to make informed decisions about their care, make sure that they understand their treatment options, including risks, benefits, and support them in expressing their preferences. Um, Beneficence versus non malfeasance. We want to focus on acting in the best interest of the patient, which is beneficence, while minimizing harm, which is non malfeasance. We want to provide pain relief and comfort oriented care, especially considering the unique needs of patients should they be at the end of life. Cultural competence. We want to recognize and respect cultural and religious beliefs that influence patients' views on health, illness, and death. We want to incorporate cultural considerations into care practices to provide respectful and personalized service. Effective communication. We want to foster open, honest communication with patients and their families, use clear language and avoid medical jargon, use interpreters or bilingual staff as needed to ensure understanding. We want to work in interdisciplinary collaboration to include social workers, chaplains, healthcare providers, medical neighborhood team members to address the diverse needs of patients. We want to make sure that we're sharing insights and perspectives that enhance decision making and care planning. We want to address emotional and spiritual needs of patients and their families by providing empathetic support and access to counseling resources. We want to recognize the importance of spiritual care in enhancing the quality of life for patients facing serious illnesses. We want to have an ethical decision making process to help navigate complex situations considering all stakeholders involved. We want to document and reflect upon ethical dilemmas to foster learning and improve care processes. We want to involve families, um, members in discussions about care plans as they often play a crucial role in supporting the patient's wishes and emotional well being. We want to make sure that we're understanding the cultural dynamics that influence family involvement. And we want to make sure that we're, upholding patient confidentiality and protect private health information in accordance with legal and ethical standards. And we want to ensure that all staff members are aware of the importance of maintaining confidentiality in all aspects of care. So those are the key takeaways from today. So thank you very much. In conclusion, by embracing these key ethical principles, hospice and home care staff can create more compassionate, respectful, and effective care environments. Upholding ethical standards enhances the quality of care and supports the dignity and rights of patients and their families at a crucial and critical time in their lives. And making a commitment to ethical practice is foundational to the mission of providing exceptional hospice and home care services. Thank you very much.